Good afternoon. I am Dr. RUKMINI, Associate Professor of Anesthesiology in Department. Today we are going to discuss about neuromuscular junction physiology and pharmacology. So coming to the definition, the neuromuscular junction is a synapse at which the electrical impulse travels down the motor nerve, releases a chemical neurotransmitter which causes the muscle to contract. The anatomy of the neuromuscular junction consists of the following parts: a presynaptic membrane, synaptic cleft, and a postsynaptic membrane. Coming to the morphology, the neuromuscular junction is specialized on both the nerve and the muscle side to transmit and receive chemical messages. Each motor neuron runs without interruption from the ventral horn of the spinal cord or medulla to the neuromuscular junction as a large myelinated axon. As the motor neuron approaches the muscle, the neuron repeatedly divides to come into contact with many muscle cells, and together they form into a functional group known as the motor unit. As we see in the picture, the motor unit consists of the nerve fiber plus the muscle or the muscle fibers. It innervate together form the motor unit. The architecture of the nerve terminal is different from that of the rest of the axon. As the terminal reaches the muscle fiber, it loses its myelin, forms a spray of terminal branches against the muscle surface, and is covered by the Schwann cells. The nerve is separated from the surface of the muscle by a gap of approximately 20 nanometers, and it is called as a junctional cleft or the synaptic cleft. The nerve and the muscle are held in tight alignment by protein filaments called as the basal lamina that span the cleft between the nerve and the end plate. The muscle surface is heavily corrugated with deep invagination of the junctional clefts, primary and secondary clefts between the folds in the muscle membrane. Thus, the end plate's total surface area is very large. The depth of the folds also vary between the muscle types and the species. Then coming to the physiology of the neuromuscular transmission, motor unit, synaptic cleft, and the muscle end plate take part in the physiology of the neuromuscular transmission. Neuromuscular transmission occurs by a simple and straightforward mechanism. The nerve synthesizes acetylcholine and stores it in small uniformly sized packages called as vesicles. Stimulation of the nerve causes the vesicles to migrate to the surface of the nerve, then rupture and then discharge the acetylcholine into the cleft, separating the nerve from the muscle. The acetylcholine receptors in the end plate of the muscle respond by opening their channels for the influx of sodium ions into the muscle to depolarize the muscle. The end plate potential thus created is continued along the muscle membrane by opening of the sodium channels present throughout the muscle membrane to initiate a muscle contraction. So, the events at the neuromuscular junction are depolarization nerve terminal, which causes the opening of the calcium channel, that causes the entry of the calcium, which mobilizes the membrane-bound vesicle to bind to the docking protein, that causes the fusion of the vesicles and release of the acetylcholine into the synaptic cleft. The acetylcholine immediately detaches from the receptor and is destroyed by the enzyme acetylcholinesterase, which is also present in the synaptic cleft. Drugs, notably depolarizing muscle relaxants or nicotine and carbachol, which is nothing but a synthetic analog of acetylcholine not destroyed by the acetylcholinesterase, can also act upon these receptors to mimic the effect of acetylcholine and causes depolarization of the end plate. The drugs are therefore called as agonists of the receptor because they turn the receptor into an active site, at least initially. Non-depolarizing muscle relaxants also act on these receptors, but they prevent acetylcholine from binding to the receptor and thus cause depolarization by the agonists. Because these Non-depolarizing muscle relaxants prevent the action of the agonists, like for example, acetylcholine, carbacholine, succinylcholine. They belong to the class of compounds called the antagonists of the muscle acetylcholine receptors. Other compounds, frequently called reversal drugs or antagonists of neuromuscular paralysis, example neostigmine, protamine, inhibit acetylcholinesterase and therefore impair the hydrolysis of acetylcholine. The increased accumulation of undegraded acetylcholine can effectively compete with the non-depolarizing muscle relaxants and thereby displaces the later from the receptor and antagonize the action of the non-depolarizing muscle relaxants. And then coming to the action potential, the nerve terminals are transmitted by an action potential or also called as a nerve impulse, which are rapid changes in the membrane potential that causes the spread along the nerve fiber membrane. Each action potential begins with a sudden change from the resting membrane potential. And then coming to the sequence of events at the neuromuscular junction. Action potential arriving at the presynaptic terminal causes voltage-gated calcium channels to open. Calcium uptake into the terminal cause release of the neurotransmitter acetylcholine into the synaptic cleft, which are synthesized and stored in the synaptic vesicles. Acetylcholine travels across the synaptic cleft to postsynaptic membrane, which is also known as a motor end plate. So as we see in the picture, acetylcholine molecules combine with their receptor sites and cause ligand-gated sodium channels to open. So this is the same thing which is depicted in the picture that we have already discussed. Then once again, the sequence of events for the neuromuscular transmission. Arrival of action potential in the presynaptic motor axon terminals causes opening of the voltage-gated calcium channel of axon terminals and influx of the calcium from the synaptic space into the axon terminal. Calcium attracts the synaptic vesicles towards the release sides of the presynaptic membrane adjacent to the dense bars. Synaptic vesicles fuse with the membrane and empty acetylcholine into synaptic cleft by exostosis, which causes the acetylcholine bind with the acetylcholine receptors, which causes the conformational change and opening of the acetylcholine channels. That causes increase in the permeability of the postjunctional membrane to sodium channel, which causes influx of the sodium. That in turn causes the development of the end plate potential, nothing but the action potential. Spreading of action potential along the muscle fiber causes the muscle to contract. The ocular muscles slowly contract and then relax rather than quickly as do other striated muscles. They can also maintain a steady contraction or contracture, the strength of which is proportional to the stimulus received. Physiologically, this specialization apparently holds the eye in position. Ocular muscles are important to an anesthesiologist because depolarizing muscle relaxants like succinylcholine affect them differently than they do most of the skeletal muscles. Instead of causing a brief contraction followed by paralysis, the drug causes a long-lasting contracture response that pulls the eye against the orbit and contribute to an increase in the intraocular pressure. Then now coming to the neuromuscular blocking agents, which can be broadly divided into depolarizing muscle relaxants and non-depolarizing muscle relaxants. Then why do we use neuromuscular blocking drugs? These are agents. Neuromuscular blocking drugs are the agents that act peripherally at neuromuscular junction or muscle fiber itself to block neuromuscular transmission, and we need them to facilitate muscle relaxation for surgery or for mechanical ventilation during surgery or in the ICU. Coming to the site of the neuromuscular blocking agents, They can be divided into two types: pre-junctional receptors and the post-junctional, and the drugs that act on the pre-junctional receptors and the drugs that act on the post-junctional receptors. So classification, they can be classified into two groups: depolarizing of the non-competitive type and non-depolarizing or the competitive type. So depolarizing muscle relaxants mimic the action of the acetylcholine. So therefore they are called as agonists of the neuromuscular junction. Acetylcholine is the only drug that is used clinically among the depolarizing muscle relaxants. And non-depolarizing muscle relaxants interfere with the action of the acetylcholine. They cause antagonism. Therefore they are called as a competitive blockers. Further, they are divided into short-acting, intermediate-acting, and long-acting non-depolarizing muscle relaxants. Coming to the mechanism of the depolarizing muscle relaxants, only the clinically used drug among the depolarizing muscle relaxants is succinylcholine. So succinylcholine have affinity and submaximal intrinsic activity at the neuromuscular receptor. It acts on the sodium channels, open them, and causes initial twitching and fasciculation. It does not dissolve rapidly from the receptors, resulting in the prolonged depolarization and inactivation of the sodium channels. Succinylcholine acts on the nicotinic receptors of the muscles, stimulates them, and ultimately causes them relaxation. This process occurs in two phases: depolarizing phase and desensitized phase. In the phase 1 or the depolarizing phase, it causes the muscle fasciculations while they are depolarizing the muscle fibers. Phase 2, after sufficient depolarization has occurred, phase 2 sets in and the muscle is no longer responsive to the acetylcholine released by the nerve endings. Coming to the pharmacokinetics, it is rapidly hydrolyzed by pseudocholinesterase and its action is about 3 to 8 minutes. Therefore, it is the shortest acting and the fast acting depolarizing muscle relaxant. Transient apnea is usually seen at peak of its action. In people with a liver disease or atypical pseudocholinesterase due to genetic defect, metabolism of succinylcholine becomes slow, which results in severe neuromuscular blockade, leading to respiratory paralysis and apnea, also called as a succinylcholine apnea. Coming to its pharmacological actions, on IV administration, onset is rapid within 1 minute. Initial transient muscle fasciculations and twitchings, mostly in the chest and abdominal regions, are followed by skeletal muscle paralysis. Fasciculations are due to stimulation of the muscle fibers by the discharge of action potential. Maximum is over 2 minutes and subside within 5 minutes. Succinylcholine can also be given continuously as an infusion for the longer effect. Coming to the metabolism of succinylcholine, its ED95 is 0.51 to 0.63 mg per kg. Onset of the action is 30 to 60 seconds. Duration of action is 9 to 30 minutes. It is the shortest acting neuromuscular blocking agent. It is metabolized by butyrylcholinesterase or plasmacholinesterase or pseudocholinesterase. Its actions on the cardiovascular system. Initially, succinylcholine causes hypotension and bradycardia due to the stimulation of vagal ganglia, followed by hypertension and tachycardia due to stimulation of the sympathetic ganglia. Higher doses, it can cause cardiac arrhythmias. It causes histamine release if injected rapidly. It is the preferred muscle relaxant for endotracheal intubation. Coming to the adverse reactions, it can cause muscle pains because of the fasciculations, hyperkalemia, and it is dangerous in patients with nerve and muscular disorders, and particularly in congestive cardiac failure patients. It can also cause cardiac arrhythmias, increase all the pressures like intraocular pressure, intracranial pressure, blood pressure due to stimulation of the sympathetic ganglia, and intragastric pressure responsible for nausea and vomiting. It also causes malignant hypothermia, which is a rare genetically determined condition wherein there is a sudden increase in the body temperature and severe muscle spasms due to release of the intracellular calcium from the sarcoplasmic reticulum. Drugs like halothane, isoflurane, sevoflurane can trigger the process. Combination of these anesthetics with succinylcholine can therefore prove fatal. And the treatment of choice for malignant hypothermia is IV dantrolene. Rapid cooling, inhalation of 100% oxygen, and control of acidosis can help in the treatment of malignant hypothermia. Coming to the contraindication of succinylcholine, as we have seen earlier, it is dangerous in patients with a nerve and muscle diseases. Nerve diseases like paraplegia, hemiplegia, Guillain-Barré syndrome, and muscular diseases like muscular dystrophies, myasthenia gravis, crush injuries, burns, rhabdomyolysis, and it is also contraindicated in glaucoma and head injury as it raises IOP and increased intracranial pressure. Now coming to the non-depolarizing muscle relaxants or competitive blockers. Coming to the mechanism of action, they have an affinity at the nicotinic receptors at the muscle end place, but no intrinsic activity. The antagonism can be decreased by increasing the concentration of acetylcholine. Non-depolarizing muscle relaxants can be classified into two types based on the chemical structure as benzyl isoquinoline compounds and aminosteroid compounds. In the benzyl isoquinoline, we have D-tubercurin, metocurrin, doxycurium, atracurium, cis-atracurium, and mivacurium. And in the aminosteroid, we have pancuronium, vecuronium, rocuronium, and rapacuronium. Non-depolarizing muscle relaxants based on their duration of action can be divided into short-acting, intermediate-acting, and the long-acting. Short-acting, the action is approximately up to 15 to 20 minutes. Intermediate-acting, they act between 20 to 50 minutes. And the longer-acting drugs, they act for more than 50 minutes. In the short-acting, we have mivacurium. Intermediate-acting, we include drugs like atracurium, cis-atracurium, vecuronium, and rocuronium. And the longer-acting, we have doxycurium, pancuronium, and pipecuronium. Coming to the mechanism of action, they cause the competitive antagonism at the postsynaptic acetylcholine receptors. In small clinical doses, they act predominantly at the nicotinic receptor site to block acetylcholine. At higher doses, they can block pre-junction sodium channels by releasing the acetylcholine. So this is the same thing that we have already discussed. Non-depolarizing muscle relaxants function as the competitive antagonists. They bind to the acetylcholine receptors but are incapable of inducing the conformational change necessary for the ion channel opening. Because acetylcholine is prevented from binding to its receptors, no end plate potential develops, and therefore the neuromuscular blockade occurs even if only alpha subunits get blocked. And coming to the clinical uses of the non-depolarizing muscle relaxants, they are co-administered with anesthetic in the induction phase to induce muscle paralysis, to facilitate surgery, especially the intra-abdominal surgeries and intrathoracic surgeries, to facilitate endotracheal intubation, and also in the mechanically ventilated patients also we can use. Use of non-depolarizing muscle relaxants in anesthesia is for the maintenance of anesthesia. For intubation where succinylcholine is contraindicated, rocuronium can be the drug of choice for pre-curization to prevent postoperative myalgias by succinylcholine. D-tubercurin, first agents to undergo the clinical investigation, its ED95 is 0.5 milligram per kg, but we are not using D-tubercurin regularly now in our clinical practice because of the its side effects like it can cause hypertension, even if the dose is less than ED95 because of the histamine release. It can also cause autonomic ganglion blockade, and it has got a long duration of action, and CVS, if it's restricted its use. It can be used drug for a pre-curization. And one of the common drug we use in our clinical practice is atracurium. Atracurium is a bis-quaternary ammonium benzyl isoquinoline compound. Its ED95 is 0.2 to 0.25 milligram per kg. Intubating dose is 0.5 milligram per kg, and the maintenance is 0.05 to 0.1 milligram per kg. It is a drug of choice in patients with renal and hepatic dysfunction. Onset of action is 3 to 5 minutes and duration is about 20 to 35 minutes. It can also cause transient drop in the systemic vascular resistance and increase in the cardiac index. It can cause bronchospasm in susceptible individuals. The duration of action can be prolonged by hypothermia and to a lesser extent by acidosis. It will precipitate as a free acid if it is introduced into a IV line containing an alkaline solution such as thiopental sodium. Two separate processes of metabolism are therefore at RUKMINI. One is for the ester hydrolysis and the other one is Hoffman's elimination. Ester hydrolysis, 2/3 of the atracurium we administer can be catalyzed by non-specific esterases, and Hoffman's elimination is only 1/3, which is nothing but spontaneous non-enzymatic chemical breakdown occurs at physiological pH and temperature. And now, if prolonged atracurium infusion can cause laudanocin toxicity. Laudanocin is nothing but a tertiary amine, a breakdown product of atracurium's Hoffman elimination. It has been associated with the CNS excitation resulting in the elevation of the minimum alveolar concentration and even precipitation of the seizures. Laudanocin is metabolized by the liver and excreted in urine and bile. Cis-atracurium is an isomer of atracurium. Its ED95 is 0.05 mg per kg and the intubating dose is 0.2 mg per kg. The maintenance dose is 0.02 mg per kg. Duration of action is 30 to 45 minutes and the metabolism is similar to atracurium, that is Hoffman's and ester hydrolysis. And the main advantage is that it does not cause histamine release even at a higher doses. And coming to its clinical uses, it facilitates tracheal intubation at a dose of 3 to 4 times of its ED95. The blockade maintained at stable levels but even by continuous infusion. Elimination independent on end organ function, so ideal for the ICU at 5 microgram per kg per minute. Mivacurium is also a benzyl quinoline derivative. It has got a short duration of action. It is presented as a mixture of 3 isomers, cis-trans, trans-trans and cis-cis. Pharmacology governed by the trans-trans and cis-trans, and ED95 is 0.08 to 0.15 mg per kg. Intubating dose is 0.2 to 0.25 mg per kg. And its side effects include histamine release, hypotension, tachycardia, flushing dose if given under a dose of more than 0.2 mg per kg, and rarely bronchospasm. Clearance, like succinylcholine metabolized by pseudocholinesterases. Then coming to its clinical uses, it causes surgical procedure relaxation and not recommended for RSI. A small dose 0.04 to 0.08 mg per kg for LME. Maintenance of relaxation by constant infusions. Then coming to pancuronium, it's a bisquaternary ammonium steroid compound. Its ED95 is 0.07 mg per kg. Intubating dose is 0.12 mg per kg. It has got a longer duration of action, that is 1.5 to 2 hours. Coming to its metabolism and clearance, 80% of the single dose is eliminated unchanged in the urine. 40% undergoes hepatic deacetylation. And coming to CVS effects, it causes increased heart rate, blood pressure and cardiac output after large doses. That is 2 times the ED95 dose. Causes uncertain but vagolytic effects on post-ganglionic nerve terminal. But it does not cause any histamine release. Clinical uses of pancuronium. Slow onset in action. Limit its usefulness in facilitating tracheal intubation. Administration divided doses. Small dose given 3 minutes before induction, that is as a priming principle, produce small but measurable acceleration. Popular in cardiac anesthesia as it counters bradycardia effect of high doses of opioids, difficult to reverse than the other intermediate acting muscle relaxants. Pipecurium. Then coming to the pipecuronium, It's a bisquaternary ammonia steroid compound. Its ED95 is 50 to 60 microgram per kg. Onset is 3 to 5 minutes. Duration is 60 to 90 minutes. Like pancuronium, excretion is mainly from the kidney. And its major advantage is hepatic cirrhosis does not affect the pharmacokinetics or dynamics of the pipecuronium. And it is 10 times less vagolytic than pancuronium. It has got no histamine release. But the thing is, it is more expensive than pancuronium. Rockinonium is a monoquaternary aminosteroid compound. ED95 is 0.3 to 0.3 milligram per kg. Onset is 1 to 2 minutes. Duration is 20 to 35 minutes. And the clearance, it is largely excreted unchanged in bile, up to 50% in 2 hours. Renal excretion occurs more than 30%. CVS effects, it causes histamine release at 4 times the ED95 dose. And also anaphylactic reactions has been described. Clinical implications, replacement of succinylcholine for rapid sequence intubation. Then rocuronium and thiopentone, we should not mix in the same syringe as it causes the precipitation. And it is also used for replacing vecuronium, and the infusion rates ranges from 5 to 10 microgram per kg per minute. Coming to the vecuronium, it is a monoquaternary aminosteroid compound. ED95 is 0.04 to 0.05 milligram per kg. Intubating dose is 0.12 milligram per kg. Onset of action is in 3 to 5 minutes, and the duration of blockade is for 20 to 35 minutes. It undergoes both hepatic metabolism and renal excretion. Coming to its effects, it can see even at a higher dose, it does not cause much significant cardiovascular effects. It has got no histamine release. Elimination half time at a dose of 0.1 milligram per kg is not increased in alcoholic liver disease. Dose is 0.2 milligram per kg IV is associated with a prolonged elimination half time and the corresponding prolonged duration of action in hepatic cirrhosis. Renal dysfunction. Elimination half-life of vecuronium and 3-D-acetyl vecuronium is prolonged with the renal failure. Coming to the clinical uses, vecuronium, because of its cardiovascular stability and intermediate duration of action, it is a suitable agent for patients with a ischemic heart disease. Like rocuronium, it should not be given with thiopentone. At large dose 0.1 to 0.2 milligram per kg, it facilitates fecal intubation. And for the maintenance, intermittent bolus 0.01 milligram per kg to 0.02 milligram per kg. And for the continuous infusion, we can use 1 to 2 microgram per kg per minute. These are all the clinical characters of the non-depolarizing muscle relaxants which we have already seen. And this is a consideration in special population, which includes in the pediatric population, succinylcholine should not be routinely given. Non-depolarizing agents cause faster onset, and the vecuronium acts as a longer acting agent in the neonates. Elderly, decreased clearance and prolonged duration, except with the cis-vecuronium. In the obese patients, dosage more than 20% more than the lean body weight, onset is unchanged. Prolonged duration except with the cis-vecuronium. Hepatic disease, increased volume of distribution, pancuronium and vecuronium, prolonged elimination due to hepatic metabolism and biliary excretion. Cis-vecuronium is unchanged. Pseudocholinesterase is decreased. Prolonged action may be seen with the patients in succinylcholine in severe disease. In the renal failure, the duration of action of vecuronium is prolonged. Rocuronium is relatively unchanged, and cis-vecuronium is the safest alternative. In the critically ill patients, myopathy, polyneuropathy, nicotinic acetylcholine receptor regulation, succinylcholine is contraindicated. And this is a slide which shows us the average duration of action of our muscle relaxants. Pancuronium is 40 to 80 minutes, pipecuronium 50 to 100 minutes, and vecuronium 20 to 40 minutes. Apicurium, rocuronium and vecuronium being an intermediate duration of action, it is about 20 to 40 minutes. Succinylcholine acts for 3 to 6 minutes. And this is a sequence of the neuromuscular blockade. The first muscle to be blocked by both depolarizing and non-depolarizing muscle relaxants are the central muscles, then the peripheral muscles. So the sequence of blockade is eyelids, muscles of the fingers, face and the neck muscles, extremities, trunk and the abdominal muscles, intercostal muscles and diaphragm. And the return of muscle activity occurs in the reverse order. Reversal of the neuromuscular blockade, the goal is to re-establish of a spontaneous respiration and ability to protect the airway from aspiration. And we use cholinesterase inhibitors. The primary use is to reverse non-depolarizing muscle blockade. Neuromuscular transmission is blocked when non-depolarizing muscle relaxant compete with the acetylcholine to bind to nicotinic cholinergic receptors. The cholinesterase inhibitors indirectly increase the amount of acetylcholine available to compete with the non-depolarizing muscle relaxants, therefore re-establish neuromuscular transmission. So antagonism of the neuromuscular blockade mechanism of action is by inhibiting the activity of acetylcholinesterase. More acetylcholinesterase therefore available at the neuromuscular junction to compete for sites on the nicotinic cholinergic receptors. Action at muscarinic cholinergic receptors causes bradycardia, hypersecretion and increased secretions and increased intestinal toll. The effectiveness of the acetylcholinesterase depends on the degree of the recovery present when they are administered. Acetylcholinesterase, which we use are neostigmine and pyridostigmine and edroponium. Neostigmine is the commonly used compound, and the onset of its action is 3 to 5 minutes. Elimination T half is 77 minutes. The dose is 0.04 to 0.7 milligram per kg. It's a quaternary ammonium compound, and its action is seen apparently in 5 to 10 minutes and lasts for more than 1 hour. Thank you.